एक आप दीजिए इंट्रोडक्शन। मैं स्टार्ट कर। So good afternoon everyone. Welcome to the NMCN Nursing Knowledge Series, which is for empowering nursing excellence. We are conducting an online longitudinal training program for nurses, which is conducted by Nexus and is conducted in collaboration with the Department of Emergency Medicine here at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. We are running in the 8th session in this longitudinal training program. This 8th session will be taken by Ms. Kanika Jain, who is a nursing officer and a graduate in BSc Honours Nursing from Lady Hardinge Medical College, New Delhi. She belongs to the 2022 batch and began her professional career here at SGPGIMS. Currently, she is working in the Department of Emergency Medicine as a nursing officer, where she is responsible for providing dedicated care in critical situations. She'll be taking up a session on oxygen therapy, delivery of oxygen therapy to patients. All the modes mostly of delivering oxygen therapy will be discussed by her. I would like to welcome Ms. Kanika Jain. Over to you, ma'am.
Thank you, Mr. Abhishek. Good afternoon, everyone. My name is Kanika Jain, and I am currently working as a nursing officer in Emergency Department of SDPGIMS, Lucknow. Today, I am presenting on delivery of oxygen therapy, which is a crucial life-saving intervention in clinical practice. So let's move on to the introduction part. Yeah, let's move on to the introduction part. So oxygen therapy is the administration of oxygen at concentrations higher than room air. It is also used to treat or prevent hypoxia and improve tissue oxygenation. It is commonly used in emergency ICU and ward settings. Now, what are the indications for oxygen therapy? So the main indications are hypoxemia, in which saturation is less than 90% and PaO2 is less than 60 mmHg, and respiratory distress or increased work of breathing. In acute and medical surgical conditions, in cardiac conditions like myocardial infarction, respiratory conditions like COPD and asthma, and in neurological emergencies like stroke. So moving forward for indications for acute oxygen therapy. So these indications are differentiated in accepted indications and questionable indications. Now, what comes in indications? In the accepted indications are those indications जिसमें हमें पता है कि हमें ऑक्सीजन थेरेपी प्रोवाइड करना ही है पेशेंट को. So what are the cases in PaO2 below normal range, usually less than 60 mmHg and less than 90% saturation, and hypoxemia strongly suspected, such as respiratory distress and severe trauma patients. In low cardiac output patients. Now, किसमें ये देखेंगे कि क्वेश्चनेबल है कि हमें पेशेंट को ऑक्सीजन थेरेपी प्रोवाइड करना है या नहीं करना है. Like in acute myocardial infarction and stroke without hypoxemia, in dyspnea without hypoxemia. Now, if we are going to elaborate on dyspnea without hypoxemia, ये कैसे क्वेश्चनेबल है कि हम इसमें ऑक्सीजन थेरेपी प्रोवाइड करेंगे या नहीं. सपोज पेशेंट को डिस्निया हो रहा है, पेशेंट को सांस लेने में तकलीफ हो रही है, लेकिन वो कंप्लेन कर रहा है कि मुझे सांस लेने में प्रॉब्लम हो रही है, और हम सैचुरेशन प्रोब लगा के देखेंगे तो उसमें सैचुरेशन इज 98 to 99%. So in that case, whether we really need to provide oxygen to that patient or not, this is the basic question. And then now sickle cell pain crisis. In sickle cell pain crisis also, we need to check कि हमें पेशेंट को सच में ऑक्सीजन थेरेपी प्रोवाइड करने की जरूरत है या नहीं. In pneumothorax and in pneumomediastinum. So now moving further for the chronic indications. Now, according to American Thoracic Society guidelines, indications for chronic oxygen therapy is given in patients who required long-term oxygen therapy. Like एक पेशेंट को 15 घंटे से ज्यादा, एक दिन में 15 घंटे से ज्यादा ऑक्सीजन थेरेपी चाहिए, whose indications are severe chronic resting hypoxemia. And criteria goes for him is PO2 is less than 55 mmHg or saturation less than 88%. It is strongly recommended for that in that case. And patient with resting hypoxemia with qualifiers. Now the qualifiers term here is basically involves PaO2 is equal to 56 to 59 mmHg or saturation 89 plus 89% plus one of the following, like in core pulmonal hematocrit less than 55%. It is strongly recommended for that patient. And in ambulatory oxygen, it is the indication includes severe exertional hypoxemia. In that case, the criteria is PO2 is less than 55 mmHg or saturation less than 88%. But the condition here goes is with the exertion. So in this, the conditional recommendation is given whether we really need to provide the oxygen therapy to this patient or not. Now moving forward for the goals of oxygen therapy, why goal is really same? Like fuel is needed for vehicle to run, oxygen is also needed for a critical patient to enhance his body work. So the goals of oxygen therapy includes maintain adequate tissue oxygenation, to reduce the work of breathing, to prevent organ dysfunction due to hypoxia, and to improve patient comfort and outcomes. Now what is tissue hypoxemia? बेसिकली अगर हम बात करें तो आर्टीरियल हाइपोक्सीमिया कैसे होगा? अगर बॉडी में डिक्रीज ऑक्सीजन इनटेक होगा तो ये किसकी वजह से हो सकता है? वेंटिलेशन परफ्यूजन इम्बैलेंस की वजह से. Now what is ventilation perfusion imbalance here? It is the ventilation perfusion imbalance is it refers to imbalance between the air reaching the alveoli and the pulmonary capillaries. Okay. Now what is the now we can also say this thing that arterial hypoxemia diffusion defect की वजह से हो रहा है, alveolar hypoventilation की वजह से हो रहा है कि एयर और फ्लूइड के बीच में स्पेस ही नहीं है. शंट ऑल्सो, इन शंट में हम ऐसे क्यों बोलते हैं कि ज्यादा इंप्रूवमेंट नहीं शो होती है? क्योंकि अगर हम आर्टरी वीनस शंट के बारे में बात करें तो आर्टरी में ज्यादा ऑक्सीजन होता है और वीनस वेन्स में कम होता है. तो अगर हम आर्टरी वीनस शंट बनाते हैं कहीं पे तो उसमें ऑक्सीजन एक तरीके से नॉर्मलाइज हो जाएगा, तो उसमें बहुत ज्यादा फर्क पड़ेगा नहीं उस चीज से. नाउ द सेकेंड थिंग इज रिड्यूस ऑक्सीजन डिलीवरी. लाइक सर्कुलेटरी हाइपोक्सिया. सर्कुलेटरी हाइपोक्सिया क्या है कि बॉडी में ऑक्सीजन दे रहे हैं लेकिन सर्कुलेशन प्रॉपर नहीं है, तो इस वजह से उसको ऑक्सीजन देने का कुछ मतलब नहीं हो रहा है और ब्लड में टिश्यू हाइपोक्सीमिया हो जा रहा है. अब नॉर्मल ब्लड ऑक्सीजन ट्रांसपोर्ट लाइक एनीमिया है, पेशेंट में हीमोग्लोबिन ही नहीं है. हीमोग्लोबिन नहीं होगा तो ऑक्सीजन ट्रांसपोर्ट कैसे होगा? हीमोग्लोबिन आर द की. नाउ लेट्स टॉक अबाउट द क्लिनिकल मैनिफेस्टेशंस ऑफ हाइपोक्सिया. It may vary from different system to system. Now let's talk about respiratory system. What are the signs and symptoms of respiratory system? Will include tachypnea, dyspnea, cyanosis. And in cardiovascular system, the signs and symptoms will be palpitation, tachycardia, arrhythmias, hypertension, angina, and diaphoresis and shock. Now what goes in central nervous system? It is headache, confusion, delirium, seizures, and coma. And for neuromuscular, it is weakness, tremors, hysteresis, and incoordination. Now, some people might not be knowing what is this hysteresis. So it is the jerking movement. Like हम कुछ चीज पकड़ रहे हैं तो हमारा हाथ शिवर कर रहा है, हम खड़े होने की कोशिश कर रहे हैं तो हमारे लेग शिवर हो रहा है. Okay. So now let's talk about the symptoms of hypoxia, as you all are aware of these things. But let's again ponder on these topics. So restlessness, headache, confusion, tachycardia, tachypnea, anxiety, and dyspnea. Now, what are the symptoms of severe hypoxia? It is slow heart rate, extreme restlessness, blue skin, that is cyanosis. Okay. So let's talk about how do we going to recognize when it is tissue hypoxia. हम कैसे assess कर सकते हैं, कैसे recognize कर सकते हैं कि tissue hypoxia हो रहा है? By clinical and laboratory parameters. Okay. And in laboratory assessment, like surrogate markers of tissue hypoxia are PaO2 and serum lactate levels. Now, we're going to differentiate between hypoxia and hypoxemia. So basically, hypoxia is a condition where there is an inadequate supply of oxygen to the body, tissue, and organs. So there are four types of hypoxia. So we'll quickly just brief about them कि hypoxic hypoxia क्या होता है. Hypoxic hypoxia is reduced supply of oxygen to the body, leading to a low arterial oxygenation tension. And what is anemic hypoxia? Anemic hypoxia में क्या होते हैं? The arterial oxygen tension is normal. अगर हम बहुत सिंपल लैंग्वेज में बोले तो एनेमिक हाइपोक्सिया इज कि बॉडी में हीमोग्लोबिन ही नहीं है, और हीमोग्लोबिन का काम क्या है? ऑक्सीजन को टिश्यूज तक पहुंचाना. नाउ सर्कुलेटरी हाइपोक्सिया कि बॉडी में तो ऑक्सीजन है बट वो सर्कुलेशन प्रॉपर नहीं है, एंड दैट इज व्हाई वाइटल ऑर्गन्स तक ऑक्सीजन पहुंच ही नहीं पा रहा है. एंड व्हाट इज हिस्टोटॉक्सिक हाइपोक्सिया? इट इज द इम्पेयरमेंट ऑफ सेलुलर मेटाबॉलिज्म ऑफ ऑक्सीजन डेस्पाइट एडिक्वेट डिलीवरी कि बॉडी में तो एडिक्वेट डिलीवरी है लेकिन इम्पेयरमेंट हो रहा है सेलुलर मेटाबॉलिज्म की वजह से कि जो सेल्स हैं वो मेटाबोलाइज नहीं कर पा रही हैं. ओके, so now let's go ponder upon hypoxemia. Hypoxemia refers to a low level oxygen level in the bloodstream. Now its causes include respiratory issues, cardiovascular problems, altitude, and anesthesia. Got it? Now we'll talk about the sources of oxygen therapy. So sources of oxygen therapy includes oxygen cylinders, central oxygen supply in hospital, and oxygen concentrators that are used in home settings. So it is crucial for nurses and transporters to ensure the oxygen tank that has an adequate amount of oxygen during transport. हमें सबसे पहले ये चेक करना होगा कि जिसको हम ट्रांसपोर्टेशन के लिए यूज कर रहे हैं क्या उसमें प्रॉपर ऑक्सीजन है भी, क्या वो खाली तो नहीं है. Whether it is turned on and the appropriate flow rate is set or not. See, the main key in the whole oxygen therapy is the flow rate. The flow rate is the gold standard for this thing. So we need to understand this thing. Okay. So now let's classify the oxygen delivery devices. So starting from the left, starting from the bottom, there are low flow oxygen delivery devices, high flow, and specialized oxygen delivery devices. So now we're going to talk about the methods of oxygen therapy. Methods of oxygen therapy includes two type of therapy methods: invasive method and non-invasive methods. What are the invasive methods? So invasive method is invasive ventilation. That is also known as mechanical ventilation. Okay. And what is the non-invasive method? So non-invasive methods again are divided into two types of systems that are and variable performance system. Okay. This fixed performance system. Now, why is it called fixed performance system? Because see, it is again classified as venturi mask, high flow nasal cannula, and NIV. Why we are calling it fixed performance? Because हम एक fixed amount में FiO2 provide करेंगे through these devices. Okay. I'll tell you about this venturi mask later on. Again, this NIV is divided into CPAP and BiPAP. So in the further slides, we're going to see on all these topics. Now, the variable performance. Now, variable performance system, why we are calling it variable? Because we can set the different FiO2s for these things, which includes low flow nasal cannula, face mask oxygen therapy, and in face mask oxygen therapy also, two types are there: simple face mask and humidified high flow face mask. Okay. So it also has three types of methods of oxygen therapy, also has three types of dependencies. If we are going to talk low dependency, see, in low dependency, what happens is the supplemental oxygen alone is sufficient to correct the hypoxia. We don't need the patient's assistance. Okay. And the respiratory pattern which we see is spontaneous breathing. And the example includes nasal prongs, standard face mask. And in medium dependency, supplemental oxygen and a degree of respiratory assistance is required, like patient's degree of respiratory assistance. इसमें हम supplemental oxygen तो देंगे लेकिन हमें patient का assistance भी चाहिए. Okay. So respiratory pattern we see in these things are spontaneous breathing but requires additional support. For example, CPAP. And the example includes CPAP mask and its equipment. What happens in high dependency? In high dependency, supplement oxygen is full and the patient's respiratory support is also full. Okay. The respiratory pattern we see is unreliable or absent completely. It requires NIPP, which is also known as non-invasive positive pressure ventilation or intermittent positive pressure ventilation. Its example involves use of intensive care, operating theater, and non-invasive ventilators. So again, based on low dependencies, for it is further divided into low flow system and high flow system. So our low flow system includes nasal cannula, simple mask, and reservoir mask. Again, this reservoir mask is divided into two types: partial rebreather and non-rebreather. Okay, and this high flow systems are divided into venturi mask and high flow nasal cannula blenders. So let's talk about them in detail. So low flow oxygen devices. First thing is nasal cannula. Through nasal cannula, the oxygen we can give is 1 to 6 liter per minute, and FiO2 is 24 to 40%. See, this is the nasal cannula. It is the simplest and most common oxygenation device. Why? Because it has a soft silicone tubings, and it has, see, as you can all see, it has two prongs which is inserted in the nostrils, and it is very easy to use, comfortable and disposable, because patient can eat, talk and drink with this. Now coming to the simple face mask, the oxygen we can provide through this is 5 to 10 liters per minute, and the FiO2 is 35% to 60%. See, this is the face mask. As you all know about the face mask, we don't need to discuss that much. The flow rate should never be set. The main thing is that flow rate should never be set below the 5 to 6 liters. Why? Because there's a risk of carbon dioxide rebreathing. Now we'll talk about non-rebreather mask. Non-rebreather mask, थ्रू non-rebreather mask हम ऑक्सीजन कितना प्रोवाइड कर सकते हैं? 10 to 15 liters per minute, and the FiO2 is 60% to 90%. See, we're going to talk about the parts of the non-rebreather mask. As you, I think you have all seen it, but let me just give you a brief detail. See, it is an adjustable nose clip. It is a metal clip. Okay, it has breathable diaphragm. There are two breathable diaphragms. It is an elastic band, and this is a PVC oxygen bag. It is a 1 liter. It is completely a 1 liter, and see, here it is a rotatable tubing connector, which is connected to oxygen tubings. Now, what is the mechanism of this non-rebreathing mask? The mechanism simply, if I'm going to say, is 100% of oxygen will going to come inside the bag. Now, this bag is half inflated. Just mark my points that the bag will be half inflated, not completely inflated. Why? Because patient is continuously breathing. So when he is breathing, the 100% of oxygen which has been filled in this bag, the patient will going to inhale, and once he will going to inhale, there is the key. There's a one-way valve here. See, this is a one-way valve. When the patient will going to breathe, so the oxygen was filled here, he will going to inhale, and when he will going to exhale, so that the exhaled carbon dioxide will not going back to again this reservoir mask. Why? Because there is a one-way valve present here, which will not going to allow the carbon dioxide to get mixed here. So the carbon dioxide will going to release from this one-way valve. Okay. So one-way valve mask between the mask and bag. This is the one-way mask and bag suitable for spontaneously breathing patients with severe hypoxia. This is used in severe hypoxic patients. Okay. Now we will go. I think we'll go.
This is a non-rebreather face mask. And what that means is that when a patient exhales carbon dioxide and then inhales, they are not inhaling the exhaled carbon dioxide. They're not rebreathing it, because this bag that's attached to it is going to be filled with 100% oxygen. However, if you place this on a patient as it comes with this crumpled up bag, when they breathe in, they'll be breathing in through this one-way valve inside the mask, and they'll be breathing in nothing, right? So we need to make sure that this is plugged in and turned all the way up, so that when our patient is actually using it and breathing in, they're breathing in that oxygen. So before we place it on our patient's face, we need to turn this bad boy up to at least 15. And now you can see that the bag is beginning to inflate, and this is 100% oxygen, and this is a one-way valve. So they'll exhale, the carbon dioxide will exit, and they'll inhale this 100% oxygen.
I hope the video was effective for you. Now we will going to talk about the partial rebreather mask. So through partial rebreather mask, we can provide 10 to 15 liters of oxygen per minute, but it only delivers 35 to 50% FiO2. See, इसमें क्या प्रॉब्लम क्या है, इसमें एक वॉल्व जो हमें जो NRBM मास्क में प्रोवाइडेड की गई थी वो यहाँ नहीं है, and see it does not contain one way valve, so the patient's exhaled air mixes with the inhaled air. यहाँ पे 100% ऑक्सीजन आएगा, बैग फिल्ड होगा, बैग विल बी हाफ इन्फ्लेटेड, एंड व्हेन द पेशेंट विल गोइंग टू इनहेल, so inhaled air and the exhaled air will going to mix in this bag, and patient may again inhale the carbon dioxide which has been filled in this bag. So this is the demerit of this bag. Now we will going to talk about the high flow oxygen devices. High flow oxygen nasal cannula. We can provide up to 60 liters per minute and up to 100% of oxygen through this cannula. This is the high flow nasal cannula. See, this patient is using. Through this high flow nasal cannula, patient can easily eat, drink, and talk. Let's talk about the parts. This is the nasal cannula, as you can see there here. It is connected to a heated wire breathing circuit. This is the circuit, and it is again connected to the respiratory humidifier, because high flow nasal cannula provides heated humidified air. Okay, and this is the respiratory humidifier which is connected to air oxygen blender. It is standing on the wheel with brakes. So it is commonly used in critical patients and high oxygen support. It may look like nasal cannula, but nasal cannula, again I'm telling this, nasal cannula is coming into low flow oxygen devices, and high flow nasal cannula comes in high flow oxygen devices. So moving further to the Venturi mask. Venturi mask is used in those patients who require a specific amount of supplemental oxygen to avoid complications like COPD. Different types of adapters are attached to a face mask that set the flow rate to achieve a specified FiO2, ranging from 24% to 50%. See, it is based on Venturi modification of Bernoulli principle. See, Venturi mask किस पे काम करता है? Bernoulli's principle पे. Bernoulli's principle पे आप लोगों को पहले से आई थिंक पता होगा, लेकिन नहीं है तो एयर यहाँ से अंदर एंटर करेगा. एज सून एज एयर ये कंस्ट्रिक्शन से, पाइप के कंस्ट्रिक्शन से एंटर करता है, उसके वेलोसिटी इंक्रीज हो जाती है, और वेलोसिटी इंक्रीज होगा तो देयर विल बी अ ड्रॉप इन द प्रेशर में ड्रॉप होगा. So Venturi mask is designed on the Venturi principle. Now this Venturi principle is the modified version of Bernoulli's principle. And what does it says? It says कि जब यहाँ से जहाँ से एयर अंदर जाएगा तो ये कंस्ट्रिक्शन की वजह से इसका वेलोसिटी इंक्रीज होगा. वेलोसिटी इंक्रीज होगा तो प्रेशर में ड्रॉप आएगा. प्रेशर में ड्रॉप आएगा तो उसको see these are the types of modification of Venturi mask, and it is completely based on Venturi principle. तो जब यहाँ से एक प्रेशर में ड्रॉप आएगा तो जो एम्बियंट इनसाइड जो ऑक्सीजन हम प्रोवाइड करा रहे हैं वो और जो एम्बियंट एयर है वो आपस में कॉम्पनसेशन करेंगे. So these holes are provided just to compensate the air and to give the precise FiO2, what is actually needed for Venturi mask and actually needed for COPD patients. Okay, these are the different adapters. It also comes with different adapters. See, it has different colors with different FiO2s and different liter of oxygen. And it also comes with adjustable Venturi valve. Okay, see, इसमें क्या होता है, इसमें एक ही में हम अपने आप FiO2 सेट कर सकते हैं. बट ये जो डिफरेंट कलर्ड है, वी नीड टू चेंज द कलर्स, एंड बेस्ड ऑन दोज कलर्स द डिफरेंट FiO2 इज सेट. ओके, आई थिंक ये वीडियो देखने से और आपको अच्छा लगेगा.
Let's talk about a Venturi mask. A venturi mask is an oxygen delivery device that gives high flow oxygen at a precise rate. You can remember this by the memory trick Venturi Think Very Accurate. Each colored attachment is a valve that determines a percentage of oxygen being delivered to your patient. These masks offer a fraction of inspired oxygen, anywhere from 24 to 50%. And the flow rate of a Venturi mask is 2 to 15 liters per
15 liters per minute. Okay. Now, again, to summarize the FiO2s delivered by common devices, we can read this. It is a table given. We can read this device from nasal cannula flow rate. Oxygen we can give is 1 to 6 liter per minute, and the FiO2 is 24 to 40%. And through face mask, the oxygen we can provide is 5 to 10 liters per minute, and the FiO2 is 35 to 60%. Through non-rebreather mask, 10 to 15 liters per minute, and the FiO2 is 60 to 90%. And through Venturi mask, as we have already learned, 2 to 15 liters per minute, and the FiO2 is 24 to 50%. And the high flow nasal cannula is 15 to 60 liters per minute, and the FiO2 is 30 to 100%. Now, why humidification of oxygen is necessary? Humidification of oxygen is necessary to prevent drying of mucous membrane. It also improves patient's comfort, and it is also essential for high flow oxygen therapy. This is the reason why humidification of oxygen is necessary. Now let's discuss on the case scenarios. The case scenario, the first scenario is COPD patient with saturation 86%. So what can be the delivery device we can use here? Just think of a second and see, in COPD patient with saturation 86%, we use Venturi mask. Why? Because we need to give that patient the precise unit of FiO2. And but what is the rationale? It avoids carbon dioxide retention. कार्बन डाइऑक्साइड रिटेंशन कैसे करेगा ये? मैंने अभी थोड़ी देर पहले बताया कि वेंचुरी प्रिंसिपल की वजह से, जो कि बर्नौली प्रिंसिपल का मॉडिफिकेशन है, ये कार्बन डाई रिटेंशन अवॉइड करता है, क्योंकि ये एम्बिएंट एयर और ऑक्सीजन एयर को कॉम्पनसेट करा देता है. Now another scenario, the second scenario is severe pneumonia with tachypnea, and the task here is that we need to prepare HNFC for this patient. So the steps include, we need to set FiO2 as prescribed. We need to set flow rate and ensure humidification. We need to monitor respiratory rate, saturation, and comfort of the patient. The main thing here is that we need to focus advanced ICU competency. Now we come to non-invasive ventilation. In non-invasive ventilation, positive pressure ventilation, it distances the collapsed alveoli and increases the gas exchanges. So the example for non-invasive ventilation is CPAP and BiPAP. Now let's move on to this. The CPAP. CPAP is also known as continuous positive airway pressure. It is used for patients who breathe on their own but need airway support. Example, obstructive sleep apnea, COPD. How does it work? It has a mask connected to a machine, delivers mild and continuous air pressure. What are the effects? It prevents airway collapse and keeps breathing unobstructed. See, this is the machine, and this is the mask connected to this machine, which is providing the proper airway to the patient while he is asleep. Now coming to BiPAP. BiPAP is the bilevel positive airway pressure. It is similar to CPAP, but it also prevents airway collapse. But the key difference here is that it has two pressure levels, higher during inhalation and lower during exhalation. See, you can see this. This is the machine. It is the same machine. It is providing the air, but it has different inhale pressure and different exhale pressure. What is the benefit? It is easier and more comfortable for patients, since patients don't exhale against constant pressure. पेशेंट को इसमें जो फोर्सफुल वहां से प्रेशर आ रहा है उसके अगेंस्ट में उनको exhale नहीं करना पड़ेगा. So this is the benefit of this BiPAP. BiPAP in acute care settings, BiPAP devices are also used for patient in acute respiratory distress as a non-invasive. कि जिन पेशेंट कुछ ऐसी सेटिंग्स हैं एक्यूट केयर सेटिंग्स हैं जिसमें हमें वेंटिलेटर पे अगर पेशेंट को नहीं डालना है तो हम पेशेंट के लिए BiPAP मशीन यूज कर सकते हैं. ओके, एंड फॉर BiPAP devices in home settings are set up in similar manner as CPAP machine for easy use. Now let's see a video based on this BiPAP and CPAP.
Sir, are BiPAP and CPAP different? You asked me to start BiPAP and not CPAP in the patient of ventilatory defect. Yes, in CPAP, we have one pressure throughout the respiratory cycle that acts like a PEEP, that is positive end expiratory pressure, that is the pressure of the air in the alveoli at the end of expiration. Second mode of NIV is BiPAP. In BiPAP, we have two pressure. The first one is IPAP, that is inspiratory positive pressure. It mainly controls on tidal volume. And difference between IPAP and EPAP is called as pressure support. Whenever you have a ventilatory defect, that is high PaCO2 in ABG, either you have to increase this pressure support or you have to increase IPAP. So let's take an example. Before starting CPAP in this patient, we took his ABG, his pH is 5.5 and his PaCO2 is 65. So what should we do? So this is a ventilatory defect. In this patient, we must start BiPAP. Now in the next patient, pH is normal, that is 7.4, and PaCO2 is also normal, but PaO2 is just 70. So what should we do? We can continue CPAP or we can start BiPAP also because this is an oxygenation defect. Thanks for watching. I hope you understood the difference between CPAP and BiPAP. Now,
So I think I hope you have understood the difference, but let's summarize it again. So the difference between the CPAP and BiPAP are, see, in this there is a single set level. In CPAP, it is a single set level for this. But in BiPAP, there are two different pressure settings. During exhalation and during inhalation, those are different. And it is not good for accommodating breathing patterns. But it is used in the complex breathing problems such as CSA and CHF COPD. It is generally recommended for obstructive sleep apnea. And in this, inhale and exhale pressure, they are the constant set pressure. But in BiPAP, inhalation constant set pressure, but in exhalation there is a lower side of constant set pressure. Now we will going to talk about the invasive ventilation, which is also known as mechanical ventilator. See, a mechanical ventilator is attached to an endotracheal tube, replaced or replaced spontaneous breathing. FiO2 can set from 21 to 100%. Now advantages: can deliver precisely controlled high FiO2 and positive.
पढ़ के तो बोल रहा है, यही तो बोल रही है. अब देखो अगला बोल के अभी बताइए.
Advantages:
रिक्वायर हाई.
कहाँ से हुआ?
क्या कह रहे हैं?
Invasive ventilation. What are the disadvantages? It requires high flows of oxygen, sedation, and it requires close monitoring, skilled staffing. The main disadvantage is it can cause lung injury. Now we are going to come to MCQ sessions.
मतलब क्या? सेशन शुरू हो गया एमसीक्यू का.
Now let's come to the MCQ questions. ICU. We can make it interactive session. So all the participants can answer the questions. Please, you can unmute the mic and you can answer the questions. A patient with saturation 82% and severe distress should receive oxygen through which A, nasal cannula, B, simple face mask, C, NRBM, and D, Venturi mask. Will anyone going to answer?
Maybe they'll unmute themselves. If they want, they can unmute and answer it.
So you can unmute yourself and tell the answers if anyone is interested. Is anyone there to answer?
You can write in chat box also.
You can write it in chat box. Okay, what can be the answer for this question? The answer for this question goes to NRBM at 15 liters per minute. In a patient with saturation 82% and severe distress, we should use NRBM at 15 liters per minute. Now let's come to the another question. The other question is, Venturi mask is preferred in CO2 COPD patient because it A delivers high FiO2, B delivers fixed FiO2, and C is more comfortable, D needs no monitoring.
I think it's B, deliver fixed FiO2.
Yes, the correct answer is the B, it delivers fixed FiO2. Very good. Now let's come to another question. The another question is 3. Reservoir bag of NRBM should be, see, I have already told you earlier and I think I have precisely said this thing to remember. Reservoir bag of NRBM should be A, fully collapsed, B, half inflated, C, removed, and D, filled with air. Anyone to answer? Anyone here knows the answer? So many times in the earlier slides, I have already mentioned. See, the reservoir bag of NRBM should be always half inflated. Okay. Now the another question. HFNC advantage includes all except A, heated humidification, B, reduced dead space, C, precise FiO2 delivery, and D, risk of carbon dioxide retention. So what can be the answer for this? I hope you all will be knowing. Anyone there to answer for this question?
कुछ लोग उस पे दे रहे हैं आंसर चैटिंग
Okay, the answer goes to. So the answer goes to. Yeah, so the answer goes to risk of carbon dioxide retention. Now, how can we monitor the oxygen therapy? We can monitor the oxygen therapy using pulse oximeter, respiratory rate and efforts of the patient, level of consciousness for the patient, and ABG analysis when indicated, only when indicated. Not every time we need to monitor through this. Now, what can be the complications of oxygen therapy? Complications of oxygen therapy includes oxygen toxicity, carbon dioxide retention, especially in COPD patients, and dryness of airway and mucosa, fire hazards. Why is this? Why in fire hazard is the complication? I'll tell you in the later slides. Now, what are the nursing responsibilities? Nursing responsibilities include, first, we need to assess patient before and during oxygen therapy. Okay. Then we need to select device and flow rate. And then we need to ensure proper fit and patient's comfort. Then we need to monitor patient's saturation, respiratory rate, and comfort. Then we need to monitor response and report. If any abnormality is present, we need to report it. Now comes for the safety precautions for oxygen therapy. So no smoking or open flames near oxygen. No smoking while. Anyone knows this? No, okay, I'll tell you. No smoking and open flames near oxygen. Why? Because oxygen is an inflammable gas. Okay. Secure oxygen cylinders properly. We need to check if equipments regularly for leaks. We need to educate people and attendants. So the most important thing is documentation. Now we come to the documentation part, which is the most important in anything. So documentation include indication for oxygen therapy, why it is needed actually. And it also includes device and flow rate set. I've already told you this thing that flow rate is the most important thing, the most fundamental thing in oxygen therapy case. Proper device and flow rate use, patient's response and saturation levels, and any adverse events or changes which have been occurred during oxygen therapy. We need to document this very carefully. Now the summary includes oxygen delivery system. Oxygen delivery system again are divided into two, low flow system and high flow system. Now what are the low flow system? It is a quick revision who have just joined for those. Now low flow system includes lower than patient inspiration flow which are variable, okay? But the high flow system includes higher than the patient's inspiration flow. Now low flow system includes nasal cannula, nasal mask and non-rebreather mask. Nasal cannula, through nasal cannula, we can provide 1 to 6 liter per minute. It is a very quick revision. So, through nasal cannula, we can provide 1 to 6 liter per minute. Through nasal mask, we can provide 4 to 10 liters per minute. And through non-breather mask, we can provide 10 to 15 liters per minute. Now, what comes in high flow system? In high flow system, it includes high flow nasal cannula and Venturi mask. Now, high flow nasal cannula, it has a flow generator, oxygen blender, humidifier, and nasal cannula. Now, in Venturi mask, corrugated tubing, oxygen ratio.
ये क्या है?
Now, let's talk about the algorithm. I think someone has unmuted their mic.
ये क्या है?
मतलब अलग अलग चीज है.
Body again of cells.
Now we will going to talk about the algorithm of oxygen therapy. So the algorithm includes oxygen therapy. See, in patients with severe respiratory compromise, with सोचो एक पेशेंट इम्पेंडिंग अरेस्ट लेके आया है आपके पास, तो आप क्या करोगे उसके? अगर कोई पेशेंट इम्पेंडिंग अरेस्ट के साथ आया है तो हम उसको इंट्यूबेट करेंगे, और अगर उसमें ऐसा कुछ नहीं है तो हम उसको असेस करेंगे कि वेदर पेशेंट को टाइप 2 रेस्पिरेटरी फेलियर तो नहीं है. अगर टाइप 2 रेस्पिरेटरी फेलियर है तो हम उसका टारगेट सेट करेंगे कि उसका सैचुरेशन 88 से 92% होना चाहिए. उसके बाद हम वेंचुरी मास स्टार्ट करेंगे विद अ वेरी प्रिसाइज FiO2 24 to 28%. देन हम एक एबीजी कराएंगे और उसका FiO2 अगर हमें कम करना है तो हम कम करेंगे, और उसका सैचुरेशन वी विल गोइंग टू मेंटेन टिल 92%. टू हाउ कैन वी चेक इट? अगर इसमें पीएच इनका 7.35 से कम है तो PCO2 is more than 45, we will going to use NIV for this patient or invasive ventilation for this patient after consulting. And if the pH is more than 7.35 and the PCO2 is less than 45, we will going to treat the patient with lowest dose of Venturi mask, keeping the saturation is 88 to 92%. And what is the main important thing here is, the important thing here is we need to repeat the ABG after 60 minutes just to check whether the target we have set about the saturation for 88 to 92% it is maintained or not. And if there is no type 2 respiratory failure, what we will going to do? We will going to target the set the target saturation 94 to 98%. आफ्टर दैट उसमें हम फिर से चेक करेंगे सैचुरेशन अगर 85 से 94% है तो हम एबीजी में चेक करके पेशेंट को नेजल कैनुला स्टार्ट करेंगे फॉर 2 to 6 लीटर पर मिनट, और सिंपल फेस मास्क फॉर 5 to 10 लीटर्स पर मिनट. और अगर पेशेंट का सैचुरेशन 85 कम है तो उसके बाद हम उसको रिजर्वायर मास्क शुरू करेंगे 10 to 15 लीटर्स पर मिनट पे. आई होप यू ऑल अंडरस्टैंड द एल्गोरिथम. Now, the conclusion. The oxygen therapy is a critical life-saving intervention, and appropriate delivery and monitoring are essential for this for oxygen therapy. And nurses especially plays a key role in safe and effective oxygen administration. Thank you. Anyone has any question, please unmute the mics and please let me know. I'll brief about the topic again.
You can open the chat box. If they have questions, they can write in the chat box also. Yes, yes.
Stop share.
Does anyone has any question? If anyone want me to explain anything again, I can explain it again. Thank you.
Well done, Kanika. Our next session, I think 27th February, by Dr. Saurabh Singh, and topic is conflict management.
So thank you so much, Ms. Kanika, for an
Hello,
insightful
my
and
one question.
articulated session.
Yes, anyone there?
Nasal cannula, and what difference between nasal cannula and nasal prong?
Sorry, you are not audible properly. Can you please repeat the question?
Is what the difference between nasal cannula and nasal prong?
Nasal cannula and nasal prongs. See, nasal prongs has two soft. It is a soft. It has soft tubings. It has two prongs which are inserted in complete the nostrils. And in nasal cannula, it is a different scenario. We will going to place in the nasopharynx. The cannula is being placed in the nasopharynx completely. Is my point clear?
Yeah, how many times nasal cannula to be inserted? The time duration?
How many times?
How many time duration for nasal cannula?
How many times for nasal cannula?
Yes, I think he wants to know.
See,
So kindly elaborate the question a little bit.
How many
Hello, sir, you're
time duration
not
for nasal cannula? It is for admitted patient only, na?
for? Actually, you're not audible properly, so I'm not getting what are you asking. Can you please?
So you can also type it if you want, sir. Actually, we have a little difficulty in understanding the question. We have another question from Miss
Nasal
Varsha.
cannula का time के लिए हम कब तक नेजल कैनुला पेशेंट को डाल के रख सकते हैं?
कब तक नेजल कैनुला हम पेशेंट को डाल के रख सकते हैं?
nasal cannula हम कब तक डाल के रख सकते हैं पेशेंट को?
Patency.
Once it is inserted, we need to check. We need to check the saturations again to check whether the patient really need the nasal cannula or not. Because after a certain time, we have another question: how much target saturation in case of COPD? So in the target saturation for in case of COPD is 90%, 90 to 92% maximum, not more than 92%. Hello, Miss Varsha, are you getting my point? Thank you.
Okay, since we don't have any more questions, so thank you so much, Ms. Kanika, for an insightful and well articulated session on the delivery of oxygen therapy. The explanations were clear with practical approaches and emphasis on correct techniques and patient safety made the session highly informative and clinically relevant. We truly appreciate your valuable contribution and the clarity you brought into this important topic. Now, to end the session, I would like to thank our patron, Dr. R.K. Singh, who is our head of department at the Department of Emergency Medicine here at SGPGIMS Lucknow. We also would like to thank our co-patron, Professor Dr. R. Harshvardhan, our medical superintendent here at SGPGIMS Lucknow, our program in charge, Dr. Tanmoy Ghatak, additional professor at Department of Emergency Medicine at SGPGIMS, our program co-in charge, Dr. Utsav Anand, assistant professor at Department of Emergency Medicine at SGPGIMS, and our program coordinator, Ms. Juin Datta Ghosh ma'am, senior nursing officer at Quality Cell in Department of Hospital Administration at SGPGIMS. So thank you so much. Thank you all the participants for joining in. It was a highly interactive session and it was all possible because of the efforts that you made and the time that you spared for this session. Thank you so much. Thank you for joining.
Thank you.